Hi everyone, welcome to the Asia Pacific Glaucoma Society Masterclass. A very good afternoon, Assalamualaikum, and selamat petang to those who have dialed in. It's 4 p.m. in Kuala Lumpur now. It's a bit gloomy. I hope it's a better weather wherever you are at. My name is Mimiwati Zahari. I will be your moderator for today's activity. I am currently a professor in the Department of Ophthalmology, University of Malaya, and am currently practicing in the University of Malaya Medical Center and also the University of Malaya Specialist Center. Currently, I am a member of the Malaysian Glaucoma Society and am also on the board of the APGS. Before we get started, I'd like to go through a couple of items. The Asia Pacific Glaucoma Society welcomes everyone to become a member of the society. APGS is not only open to glaucoma specialists, but also to all ophthalmologists in general, researchers, trainees, associates, and corporations with affiliation in glaucoma. There are many reasons to join APGS, and in the screen are just a few items which we can share with you. You can register as a member by scanning this QR code, and all APGS members gain access to all recordings of the previous APGS joint symposiums, masterclasses, and webinars. One final disclaimer, presentations are intended for educational purposes and do not replace independent professional judgment. After the conclusion of the event, you will receive a short feedback survey, and we would really appreciate you taking a moment to complete it. And now to start the first presentation, it is with immense pleasure that I introduce Professor Catherine Liu, who will be discussing glaucoma medication therapy, current concepts, and new developments. Dr. Catherine is a professor of ophthalmology in School of Medicine in National Yang Ming Chiao Tung University, Taipei, Taiwan. She was chairperson of the department in the Taipei Veterans General Hospital from 2015 till 2022, and the immediate past president of the Ophthalmological Society of Taiwan from 2017 till 2020. Prof. Liu is currently a board member of the APGS, and in fact, she was one of the steering committee members who facilitated the establishment of the Asia Pacific Glaucoma Society. She has been dedicated to clinical practice and research in the field of glaucoma, as well as medical education and prevention of blindness for more than 35 years. An established researcher with more than 140 publications, she is a reviewer for many prestigious journals and is currently the Associate Editor-in-Chief for the Taiwan Journal of Ophthalmology. May I present to you Professor Liu with a talk which will last about 40 minutes.
Hello, everyone. Welcome to APGS Masterclass. I'm Catherine Liu from Taiwan. Today, I'm going to share current concepts and the new developments in glaucoma medication therapy. Glaucoma is a heterogeneous group of progressive optic neuropathy which share similar characteristics, and multiple factors may be involved in the pathogenesis. As of today, reduction of intraocular pressure is the only treatment which effectively preserves visual function in glaucoma. Estimates based on some studies suggest that each 1 mm mercury reduction in IOP is associated with an approximately 10 to 19% reduction in the risk of glaucoma progression. So each 1 mm mercury IOP reduction matters. Meanwhile, a majority of glaucoma patients require topical medication to reduce their IOP, even after they've received laser or surgery. There are some concepts which should be kept in mind while giving all prescriptions. In general, we start with one medication so we can be sure of the efficacy and the safety of one particular drug for one particular patient. Second, drug with contraindication should be avoided in the first place, such as avoiding beta blockers for patients with heart failure. Mostly, drugs with good IOP lowering efficacy and once daily dosing are drug of choice because they increase the chance of achieving target pressure with monotherapy, and the simple dosing schedule help increase patients' adherence. Have the patient come back 2 to 4 weeks later to see whether the reduction in LP is in line with expectation, whether the target pressure has been achieved, and whether the systemic and ocular adverse effects of the drug are acceptable and tolerable. Several landmark trials support the clinical practice of setting a target diurnal IOP in the treatment of patients with open-angle glaucoma or ocular hypertension. Target pressure refers to an IOP level below which the rate of disease progression is believed to be slow enough to minimize the patient's risk of further vision loss in his or her lifetime. Since it's just an estimated value, the clinician must continue to evaluate the stability of the structural and functional measures in glaucoma, even if target pressure has been achieved. While estimating target pressure, factors including the extent of optical damage, pre-treatment IOP, corneal thickness, life expectancy, family history of vision loss caused by glaucoma, systemic blood pressure, rate of progression, and history of this hemorrhage all have to be considered. In daily practice, we can set target pressure based on the severity of visual field defect as a reference. The more severe the defect is, the lower the target pressure to be. For cases with normal tension glaucoma, it's more sensible to set target pressure to a % reduction of IOP from the pretreatment level. The initial target pressure may need to adjust to a lower or higher level during the course of follow-up visits. Before adjusting the target to a low level, which will require surgical intervention, it's advised to first make sure whether the patient is adherent to medications and use the drugs appropriately. Here shows a flowchart from European Glaucoma Society guideline. If the first drug is effective, but target pressure is not reached, second or even third drug should be added, while laser trabeculoplasty may be considered for open-angle glaucoma. When target pressure is not reached using 3 drugs, options other than medical therapy should be considered. In addition to the mean IOP lowering efficacy, we have to be aware that the effect on nocturnal IOP differs across different classes of medication. In a prospective open-label study with crossover design, the researchers found both timolol and the tenofovir significantly reduced the mean IOP from baseline in the diurnal period. But in the nocturnal period, supine IOP with timolol was not different from that with no treatment, and significantly higher than that with the tenofovir treatment. Another study focusing on brimonidine, 0.1% in patients with open-angle glaucoma or ocular hypertension, concluded that although brimonidine lowered IOP during the diurnal period, it did not significantly lower IOP during the nocturnal period. Whenever multiple medications have to be used, fixed combination formula should be considered. The advantages are reduced number of drugs per day, less exposure to preservatives, and less expensive. The drawbacks include the IOP lowering effect of the 2 components in fixed combination formula may not be fully additive, and the adverse effects are the same as for both drugs given individually. Glaucoma may occur in women of childbearing potential, and the treatment must consider the risk to both the mother and the fetus. None of the anti-glaucoma drugs has been proved to be absolutely safe in such patients. So minimize the use of medications whenever possible is the preferred practice, and every effort should be exercised to minimize their systemic absorption. Alpha-2 agonist is the only glaucoma drug listed as FDA pregnancy safety category B, indicating no evidence of risk in humans. The others belong to category C, which means human studies are lacking and animal studies are either positive for fetal risk or lacking as well. Here shows a table of recommendation. For women in pregnancy, brimonidine is the drug of choice, but should be discontinued close to time of delivery. Beta blockers, the tenofovir, and the topical carbonic anhydrase inhibitor could be used with caution, while ROCK inhibitor and the tenofovir BUNO should be avoided. For nursing mother, brimonidine should be avoided. The tenofovir and the topical CAI are reasonable choices. Over the past decade, development regarding topical glaucoma medication therapy is booming. Before 2014, the most commonly prescribed ocular hypertension medications reduce IOP by decreasing aqueous humor production or increasing UV square outflow. They leave the diseased trabecular meshwork untreated, so IOP often continues to rise over time, owing to continuous deterioration and dysfunction of the trabecular meshwork. Pilocarpine increases trabecular outflow by contraction of long ciliary muscle rather than modulation of the trabecular meshwork, and the ocular side effects of it make it unpopular and only used rarely. Rho kinase can promote contraction of ectomyosin, increase cell stiffness, modulate cell adhesion, organize the extracellular matrix, and regulate calcium-independent smooth muscle contraction. In 2014, the first Rho kinase inhibitor available for clinical use against glaucoma and ocular hypertension, ripasudia, was on market in Japan. It causes dose and time-dependent reversible relaxation of the cytoskeleton of trabecular meshwork Schirm's canal pathway. It also decreased production of fibrotic extracellular matrix and increases permeability of Schirm's canal endothelium cell. Ripasudia 0.4% inhibit both ROCK1 and ROCK2. It's used twice daily. Upon instillation, the maximum reduction of IOP is reached after 2 hours. The plasma concentration of ripasudia peaked after 5 to 15 minutes and disappeared rapidly. This one-year prospective multicenter study for POAG, ocular hypertension, and exfoliation glaucoma demonstrate the mean IOP reduction for ripasudia monotherapy was 2.6 to 3.7 millimeter mercury. Although eyes with baseline IOP of at least 21 millimeter mercury showed the greater reduction, the IOP lowering effect was significant in patients with untreated IOP lower than 21 millimeter mercury. There was a high instance of conjunctival hyperemia. However, most of these findings were mild, transient, and resolved spontaneously. The events of allergic blepharitis and conjunctivitis were seen after administration of ripasudia for more than 8 weeks, and numerous patients withdrew from the study due to these events. These inflammatory reactions were mild to moderate, and all the events resolved without treatment or with steroid or other eye drops after ripasudia was discontinued. When ripasudia was added to prostaglandin analog, The mean further reduction in IOP was 1.4 to 2.4 millimeter mercury, whereas a mean further reduction of 2.2 to 3 millimeter mercury was shown when it was added to beta blockers. Ripasudil showed similar additive IOP lowering effect to PGA and the beta blockers when compared with the commonly used second-line glaucoma medications such as carbamide anhydrase inhibitors and brimonidine. Of note is that the incidence and the severity of ripasudil-induced conjunctival hyperemia was similar in monotherapy and combination therapy with other glaucoma medications. This study demonstrated that ripasudil could reduce IOP by around 20% in uveitis glaucoma, exfoliation glaucoma, and steroid-induced glaucoma. In more than 300 eyes, the mean overall IOP reduction from baseline at 1, 3, and 6 months were all statistically significant. In addition, a higher baseline IOP was related to a greater IOP reduction. This post-marketing prospective study of ripasudil showed a significant decrease in IOP for all types of glaucoma except neovascular glaucoma, and for all categories of baseline IOP. The most common adverse drug reaction are conjunctival hyperemia, blepharitis, conjunctivitis, and eye pruritus. No new safety signals were identified. About 30% of patients discontinued ripasudil by 12 months. Nitasudil mesylate is an inhibitor of ROR kinase and a non-epinephrine transporter. It's able to inhibit both ROC1 and 2 at a potency 20 times greater than other ROC inhibitor. In addition to increased aqueous outflow via an expanded trabecular meshwork and the dilated episcleral vessels, it also reduces aqueous humor production. Nitasudil is converted to its active metabolite by corneal esterase. Upon instillation, it produces maximum reduction in IOP between 4 to 8 hours after the third daily dose. The findings from a study of enucleated human eyes indicate that nitasudil induced an additional increase in active filtration distal to Schramm's canal. This randomized double-masked study demonstrates that the 0.02% concentration of AR13324, later named nitasudil, seemed to reach the top of the dose response curve. On day 28, the reduction in IOP by AR13324, 0.02%, was less effective than the tenofovir and did not meet the criteria for non-inferiority. However, in a pre-specified subset of patients with baseline IOP at most 26 millimeter mercury, nitasudil 0.02% and the tenofovir were similarly effective at all time points, suggesting that the ocular hypertensive efficacy of nitasudil may be less dependent on baseline IOP than has been reported for other ocular hypertensive medications. The major adverse drug reaction was ocular hyperemia, which is noted in more than half of the patients and more common than that in the tenofovir group. Other ocular side effects include increased lacrimation and subconscious hemorrhage. When compared with timolol BID, the pooled data from 2 phase 3 randomized double-masked clinical trials, ROCKY 1 and 2, found the mean reduction from baseline IOP at 3 months for both nitasudil QD and BID met criteria for non-inferiority to timolol in patients with maximum baseline IOP lower than 25 millimeter mercury. In ROCKET-2, BID dosing of nitazoxanide 0.02% was not as well tolerated as QD dosing, resulting in a higher percentage of discontinuation. These studies showed no nitazoxanide-related systemic safety issue. The long-term results from the 12-month ROCKET-2 study confirmed the persistent hypotensive efficacy of nitazoxanide 0.02%. Another study performed pooled analysis of data from the ROCKET-1 to 4 phase 3 studies of once-daily nitazoxanide or twice-daily timolol in patients with open-angle glaucoma or ocular hypertension. The authors found the IOP-lowering efficacy of once-daily nitazoxanide was stable across baseline IOP, produced the same amount of absolute IOP reduction regardless of baseline IOP, which may be related to its distinct effect to dilate the episcleral venous pressure. For patients with maximum baseline IOP up to 30 millimeter mercury, a greater percentage of timolol-treated patients achieved 20% reduction in IOP than that in nitazoxanide-treated patients. In contrast, for patients with lower maximum baseline IOP, a greater percentage of patients treated with nitazoxanide achieved 20% reduction in IOP. Conjunctival hyperemia is the most frequent ocular adverse event. It was mild in most cases, did not increase with continued dosing, and is believed to be due to ROCK inhibition of calcium sensitization, which leads to relaxation of blood vessel smooth muscle and consequently vasodilation. Since it's transient, nighttime dosing of nitazoxanide is recommended. However, the ROCKET-2 study noted that the incidence of hyperemia increased over the course of the study. Thus, we still have to keep an eye on this adverse event. Other common adverse drug reactions included corneal verticillate and subconch hemorrhage. The hemorrhage is commonly small, unilateral, petechial microhemorrhage near the limbus. Corneal verticillata result from accumulation of phospholipids within the lysosome of corneal epithelial cells. It's mild, not associated with visual change, and self-resolving after cessation of therapy. The mean time to resolution after discontinuation of the medication was about 1 year. Other ocular adverse events reported after marketing include reticular corneal epithelium edema and punctus stenosis. Both are reversible after discontinuation of nitazoxanide. In clinical practice, approximately 40% of patients will require adjunctive treatment to maintain IOP control within 2 years of initiation of prostaglandin monotherapy. Multiple agents with complementary mechanisms may enhance IOP reduction in effect, but multiple bottles of eye drop are associated with complicated dosing regimen and reduced medication adherence. A once-daily fixed-dose combination product will provide greater efficacy, but not compromise adherence. Upon installation of the fixed combination, nitazoxanide, the tenofovir, FC, and L, the reduction of IOP begins after 3 to 4 hours, reaches a maximum after 8 to 12 hours, and is maintained for at least 24 hours. In the phase 3 Mercury 2 study, which lasted for 3 months, the IOP lowering effect of nitazoxanide, the tenofovir fixed combination, met the criteria for superiority to its individual active components at all study time points. Percentage reduction from baseline in mean IOP was 30 to 35% for the fixed combination product. An impressive 59% of fixed combination treated patients achieved at least 30% reduction in mean diurnal IOP versus 21% in the nitazoxanide treated or 30% in the tenofovir treated patients. Meanwhile, significantly greater percentage of patients achieve IOP of at most 16 millimeter mercury in the fixed combination group as compared with nitazoxanide and the tenofovir group, respectively. Almost all adverse events of the nitazoxanide, the tenofovir fixed combination were ocular events, and almost all of them are associated with nitazoxanide. Asymptomatic change in the appearance of corneal endothelium cells as detected by specular microscopy was reported in 5.7% of those treated with fixed combination and 4.7% of those treated with nitazoxanide and none in the tenofovir group. However, there was no report of clinically meaningful changes in endothelium cell density, corneal thickness, and corneal edema. Pooled efficacy and safety data from Mercury 1 and 2 studies showed similar results. By month 3, almost threefold higher proportion of patients in the fixed combination group achieved a mean diurnal IOP of at highest 14 millimeter mercury, and a greater proportion of patients achieved at least a 40% reduction from baseline as compared with the nitazoxanide and the tenofovir group. Similarly, systemic adverse drug reaction were minimal, and the ocular ADR are as expected. 5% of patients in the fixed combination group and the nitazoxanide group withdrew from the study due to hyperemia, respectively. The tenofovir Buno is a novel nitric oxide donating prostaglandin analog. The molecular structure of LBN is nearly identical to that of the tenofovir, but distinguished by the integration of an NO donating moiety. Both active moiety of LBN independently low IOP via two distinct mechanisms. The tenofovir acid increases the UV screen outflow, and NO increases the trabecular meshwork Schramm's canal outflow. While LBN and ROCK inhibitors mediate cytoskeletal relaxation of TM cells through Rho kinase inhibition, LBN is thought to promote cell relaxation through multiple additional mechanisms. Upon instillation, IOP reduction occurs 1 to 3 hours after the first dosage and reaches maximum effect after 11 to 13 hours. The Voyager study is designed to compare the efficacy and safety of 4 different concentrations of LBN ophthalmic solution with the tenofovir. Significant IOP reduction was observed in all groups, but reduction in mean diurnal IOP was statistically significant greater in patients treated with LBN 0.024% and 0.04% compared with the tenofovir at day 28. LBN 0.024% was the lower of the 2 most effective concentration with comparable side effects relative to the tenofovir. The Apollo study is a phase 3 study to compare the diurnal IOP lowering effect of LBN 0.024% every evening versus Timolol BID in patients with open-angle glaucoma and ocular hypertension. At all time points, the mean IOP and the mean IOP reduction from baseline in the LBN group was significantly different from those in the timolol group. Meanwhile, the percentage of patients with mean IOP 18 millimeter mercury or lower and the percent reduction in IOP 25% or greater were significantly higher in LBN group versus timolol group at all time points. In this study, drug-related adverse events were very uncommon and similar in both groups. The overall proportion of subjects with ocular hyperemia was similar between treatment groups, but a greater proportion of subjects in the LBN group were rated as having moderate to severe hyperemia compared with subjects in the timolol group. The proportion of patients experiencing more than one non-ocular adverse events was comparable in the two groups. A similarly designed clinical trial, the LUNA study, showed mean IOP reduction with LBN was greater than that with timolol at all but the first time points, with an additional 1.2 millimeter mercury reduction in diurnal IOP with LBN as compared with timolol at 3 months. 17% of LBN treated patients and 11% of timolol treated patients had their IOP reduced to 18 millimeter mercury or lower at all time points. The percentage reduction in IOP, more than 25% from baseline, was achieved in 31% of LBN treated and 19% of timolol treated patients, respectively. Conjunctival hyperemia, eye irritation, and eye pain are the most common ocular adverse events in patients treated with LBN, showing a greater proportion than that noted in the timolol group. Jupiter study is a single-arm, multicenter, open-label clinical study conducted in Japan, which includes patients with normal tension glaucoma, pigmentary, and pseudo-exfoliation glaucoma. In the study eyes, a 20% reduction in IOP to 15.3 millimeter mercury was achieved by week 4. At week 52, the percent reduction in IOP was 26% in the study eyes. The most common adverse events were similar to those identified in the Apollo and LUNA study conducted in United States and Europe. Overall, the adverse effect profile of LBN was similar to that of prostaglandin analogs. The constellation study compared the diurnal and the nocturnal IOP and ocular perfusion pressure in LBN treated versus timolol treated patients. Both treatments reduced diurnal IOP to the same level. Nocturnal IOP in timolol treated patients was unchanged from baseline, but in the LBN, it was 2.5 millimeter mercury lower than baseline and 2.3 millimeter mercury lower than timolol. LBN treatment also resulted in greater diurnal ocular perfusion pressure relative to baseline and greater nocturnal OPP relative to timolol. FP receptors agonists have the advantages of good efficacy, few systemic side effects, and one steady dosing regimen, so they are commonly used as first-choice medication in the management of glaucoma. However, in addition to the well-known ocular side effects, after long-term treatment, prostaglandin-associated periorbital palsy, PAP, may occur, which include deep superior eyelid sulcus, anosomos, ptosis, flat tight eyelids, and narrow eye fissure. PAP has become a major concern because it may cause difficulty in the measurement of IOP and is associated with worse outcome after trabeculectomy. Meanwhile, Patients' adherence may be poorer out of cosmetic concern. Omidanipac isopropyl, OMDI, is a topical ocular hypertensive agent approved in Japan in 2018 for the treatment of glaucoma and ocular hypertension. Its active metabolite, omidanipac, is a highly selective non-prostaglandin prostanoid EP2 receptor agonist. It reduces IOP by an increase in aqueous humor outflow by both the trabecular and the uveal ground outflows. In phase 1 study on healthy subjects, mean IOP was reduced by 4 to 5 millimeter mercury from baseline 2 hours after OMDI application, reaching the maximum effect and remained stable from 3 days onwards. OMDI stimulates the EP2 receptor, which is a transmembrane receptor and causes elevation in intracellular adenosine cyclic AMP and various signaling cascades in the cell body and trabecular meshwork. OMDI has no or little effect on adipocyte differentiation, adipogenesis, and eyelash growth, which are PEP-related organizational changes seen with the use of FP receptors. The phase 3 AYAMI study compares OMDI versus latanoprost. At week 4, mean reduction in IOP from baseline was 5.9 millimeter mercury in OMDI-treated eyes and 6.6 millimeter mercury in latanoprost-treated eyes. It was numerically in favor of latanoprost, but the difference was below the non-inferiority margin and within the measurement limit by Goldman apprenation tonometry. So the conclusion was that OMDI was non-inferior to latanoprost. The maximum IOP reduction was achieved within 1 week of treatment and remained stable over the 4-week study period. There was no withdrawal from study related to the study drug. The common treatment-related ocular adverse events were conjunctival hyperemia, corneal thickening, and punctate keratitis. The mean increase in corneal thickness was not clinically significant because it was within the range of normal physiological change, which occurs after 1 night of sleep. Conjunctival hyperemia induced by OMDI peaked at 30 minutes to moderate severity and reached a level not significantly different from baseline value at 2 hours. The severity of hyperemia was less than that noted with rhipassudia treatment. This 52-week phase 3 range study demonstrated that OMDI, either as a monotherapy or used concomitantly with timolol, resulted in significant and stable IOP reduction for patients with ocular hypertension and open-angle glaucoma, including normal tension glaucoma. The most common adverse event was conjunctival hyperemia, being 19% with OMDI monotherapy and 45% with concomitant treatment. The next common reported ocular adverse event was macular edema, including cystoid macular edema, which is the most common reason for study discontinuation. All cases of treatment-related macular edema occurred in pseudophakic eyes, with an incidence of 48%. As a result, aphakia and pseudophakia are listed as contraindications of OMDI. It's also advised to avoid concomitant use of OMDI and FP agonist. The increase in corneal thickness was not associated with changes in corneal endothelium cell density or corneal edema. For patients who are non or low responder to the tenofovir, an additional 23% reduction in mean diurnal IOP could be achieved after switching from the tenofovir to OMDI without washout period in between. There were no severe safety concerns, and the severity of adverse drug reaction with the tenofovir did not increase after switching to OMDI. However, we have to keep in mind that both FP agonist and EP2 agonist are pro-inflammatory mediators, and ocular inflammation is listed as a precaution in the label of both drugs. How does OMDI behave during nocturnal period? This study found in sitting position, the mean IOP over 24 hours was consistently lower with OMDI treatment compared with the baseline level. The habitual position IOP and the OMDI treatment was significantly lower than the baseline IOP, except at 5 a.m. and 5 p.m. OMDI reduced peak IOP and minimum IOP during the 24-hour period of observation. However, this is a study of small sample size, and more studies are needed to understand the 24-hour IOP profile with the treatment of OMDI. Several studies reported that some manifestations of PAP may recover after switching from conventional PGA to OMDI. Recovery of DUS was most frequently observed at 50%, whereas hypertrichosis was the least observed at 8% after 12 months follow-up. This study enrolled 100 patients who received initial treatment with OMDI or tafloprost in only one eye for 6 months or longer, and found the frequency of periocular adverse reactions to OMDI ranging from 0 to 2%, lower than those to tafloprost. Take-home messages are: for chronic medication treatment of glaucoma, start slow and keep simple as possible. Keep target pressure and a nocturnal IOP fluctuation in mind. For pregnant women, efforts to minimize the use of medication and systemic absorption of the medication should be exercised. While alpha-2 agonist is recommended for pregnant women, it should be discontinued before delivery and avoided for breastfeeding mother. New developments in glaucoma medication, which target the diseased trabecular meshwork Schenck's canal, may halt the continuous deterioration of the conventional outflow pathway and have complementary effects to drugs which increase UV square outflow or decrease aqueous humor production. For now, ROCK inhibitors and the tenoprostein buno are not recommended for pregnant women or pediatric patients. EP2 agonist rarely causes PAP and may be a good choice for young adults or cases with unilateral glaucoma who are phakic. Here I conclude my talk for today. Thank you very much for your attention. Now it's time open for discussion.
Thank you so much, Dr. Liu. That was a very comprehensive talk on the current concepts and the new developments of glaucoma medications. I'm sure there are several questions from the audience. Do I have a look at the comments? Okay. Since we have just about 10 minutes to answer the questions, let me read off the first questions. Um, there is one question which is, will these newly developed medications shift treatment paradigms for glaucoma medical therapy? All these very new drugs, and I think so far we are quite happy with what we have. Our PGAs are quite effective. So how do these new drugs come into our current practice?
Yeah, thank you for the question. And yes, for the past 2 decades, the most common first-line glaucoma medications are prostaglandin analog and beta blockers. I think it's possible for some of the new developed medication to become first-line choice. However, we need time to accumulate more and longer-term data before reaching a conclusion. For now, I think cost is a major concern because some of the new medications are quite expensive. Another concern is patients' tolerability of these medications after long-term application. And we also have to keep in mind that the use of nitazoxanide, LBN, and OMDI in pregnant women and pediatric patients are still lacking. So I think it's possible for some of these new medication to become the first line uh, and shift the treatment paradigm, but we still need some more time to observe. Thank you very much for your question.
Okay. I think that would answer Dr. Kuroyedov's question, because he was asking the perspective for these new medicines in the current paradigm. There's a question from Dr. Taya. She's asking, what would be your choice of drug monotherapy?
First
This,
choice of
yeah,
monotherapy.
in your practice.
Okay, as I have mentioned, for first-line therapy, we have to avoid contraindication in the first place, and we would like to choose once daily dosing medication with a great IOP reduction efficacy. So from what I have reviewed, we can see there are several choices which could be used as the first-line therapy, including the traditional PGA and beta blockers. But I think nowadays, if it is available, the tenoprotein buno is also a choice, a first-line choice monotherapy. For young patients, maybe who are going to use glaucoma medication for many decades, and we are afraid of the complication of PAP after long-term use of prostaglandin analog. So for those young patients, probably OMDI can be considered as a first-line therapy. So there are several choices. It depends on the patient's preference, tolerability, and the availability of the drug in your society. Yes.
Thank
I
you.
hope I have answered the question.
Yeah, I think you have very nicely.
Well, thank you.
There's two questions on regarding the effects on the cornea. One is, how long does it take for the cornea verticillata to develop? And there's another question regarding the corneal thickness. What is the implication of corneal thickness as an adverse event of glaucoma treatment in the long term? And how often should the corneal thickness be checked, as this is usually not monitored in glaucoma treatment? I think we usually take CCT as a baseline to know whether it's thick or thin cornea, but we don't actually, monitor the progression.
Yes. The corneal thickness increased after the application of OMDI. And, because this is a finding from the clinical study, so they have checked everything clearly. But in clinical practice, usually we don't repeat CCT. So my suggestion would be that a 3-lamp examination is fundamental, and you have to check whether the cornea is clear enough or not so clear. And if you want to know the change in CCT, probably you can have a baseline CCT, and then after treatment with OMDI, you may repeat CCT after 2 months application. So if corneal thickness happen before 2 months, I think because according to the study results, we know that it is not associated with corneal edema and not associated with blurred vision. It's just a finding from the measurement. So yes, we should be cautious about this change, but I think for now, it does not cause clinically significant problem.
Okay.
Yeah.
We can entertain one more question. This is from Dr. Lee. The trials focus on IOP reductions as the outcome. What is the evidence between IOP reduction and the long-term outcomes in terms of blindness and quality of life in normal tension glaucoma and ocular hypertension?
May I have the question repeated again?
Yeah, I think he's asking, the evidence now usually points to the efficacy of the IOP reduction,
Yes.
but whether there are studies to show the long-term outcomes in terms of quality of life and also blindness. But he's asking
Mhm.
about particularly normal tension glaucoma and ocular hypertension.
Okay. Because this is out of the scope of this presentation,
Yeah, yeah.
right? Because we are not focusing on quality of life, but patient's quality of life is very critical and important for the patient and his or her family. We know we have a bunch of evidence showing that IOP reduction is associated with a reduction in visual field progression. Talking about vision quality of life, uh, my personal experience is that some patients who have received trabeculectomy and afterwards they are medication free. So for these kinds of patients, after surgery, the quality of life improve much, and they no longer suffer from dry eye. But we know trabeculectomy, the result of it is not so predictable, and sometimes may have a complication, and sometimes the breath may cause some problem, such as breath-related infection or endophthalmitis, or sometimes may have a huge breath that cause patients to suffer even more. So I think this is a question not easy to answer, and the study is not easy to perform because it may varies across different patients, and also may probably depends on the surgeon's experience. A skillful surgeon after surgery may probably the patient quality of life will improve much, but for a beginner, maybe the result are not so satisfactory. And talking about ocular hypertension, I usually, because ocular hypertension means that the optic nerve and the retinal nerve fiber layer are relatively healthy. So except the pressure is very high, such as 50 millimeter mercury and 40, and cannot be controlled by medication. In that case, we will do surgery. But usually we are more conservative because the patients actually have maybe probably has still very good visual acuity and good visual field. Normal tension glaucoma, sometimes for normal tension glaucoma, the IOP is not the sole risk factor. Usually they suffer also from the low systemic blood pressure and the cardiovascular problem. So some advocates will say that we should lower the pressure in cases with progressive normal-tension glaucoma, even below 10 millimeter mercury. But again, it depends on the experience of the surgeon and the willingness of the patient. And in addition, before surgery, I would like to rule out all other risk factors which may cause the patient to deteriorate despite relative good IOP control. That's my
Okay, thank you.
response to your question.
Thank you. Can I just put in a quick question? I think for OMDR, you mentioned that the contraindication is those who are pseudophakic and aphakic because they cause cystoid macular edema. Are there
Mhm.
any contraindications for the LBN drugs?
Um, Not mentioned particularly for LBN. LBN, we know that the ternoprussic acid, the concentration of it is higher than Xarelto eye drop, but there's no mention of it. Probably the cause that not particularly mentioned about macular edema. Uh, of course, I'm talking about the healthy eye. If the eye is an inflammatory eye, we also have to avoid LBN, right? Just like we would like to avoid Xarelto in eyes with inflammation, active inflammation. But for healthy eyes, there's no mention of contraindication to the LBM just because of macular edema.
Okay, all right.